So I guess time is on. It's exactly 4 GMT right now. I would like to welcome all of the attendees and all of the panelists and the co-authors that we have. It's a pleasure to have you all. This is a webinar that is aimed to have a discussion on the position statement that is issued by the UEP on the current situation, or how to have an exit strategy in terms of the phoniatric and laryngological services, how it is possible that we stay safe, and how it is possible that we get back to the normal situation or almost to the new normal in countries that already crossed the peak of the pandemic. This position statement was issued on the 5th of May, so it is around 1 week ago, and we have a huge number of co-authors from different countries and from different interests as well, from voice to swallowing. We have, unfortunately, a low representation of those who are involved in speech and language, but we will be having more of them in the next update. We also have head and neck surgeons. And one of the things that came to our mind is that what we are dealing with is that we are trying to have the new normal. In other words, we are trying to give some recommendations on what to do in the situation in which we are right now, dealing with a totally new new situation that was never experienced before. In our first position statement that was published on the 21st of April, we were limiting to a huge extent all of the fibroscopic examination. And the idea from that was that the peak was still coming, or it was on in Italy, in Germany, and other countries. But right now, what we are trying to do is that we are trying to find the way in which we have the elective operations, the elective procedures, the elective examination is open again and possible to be offered to our patients. What we talked about is that we will have this as an open discussion in which we go from one part to the other. And the panelists, the co-authors, the participants, they are all welcome to talk, to ask questions. You will find that there is a Q and answer part of the Zoom application in which you can have your question sent to us, or that you can have your voice on by raising the hand, and then we will be unmuting the microphone. And I hope that you will find this good experience to have different ideas coming out. I would like to tell you who are the ones who are right now here. Professor John Robin from London, Haldun Aguz from Ankara, Turkey, Teemu Kinnari from Finland, from Helsinki, Jonathan Fishman, who is our dear colleague working in London, Sofia, who is in Slovakia. We also have a number of other colleagues who will be in a moment joining us. Eugenia from Mexico, she is one of the co-authors as well. And I guess we are missing some of our co-authors, but I'm sure that they will be joining us in a few minutes. John, would you like to say a few words on this position statement and the developments that came to it since the first one was published in April?
Thanks, Ahmed. First thing I'd like to do is to congratulate you on putting this group together and in helping to get these statements out. First, the one on our website, and now this one that we're hopeful will be published in JLO. I mean, it's been a tremendous piece of work, not only by you, but by all the members of the committee. And the committee is really quite extraordinary in its depth and breadth. So really, congratulations. That's the first statement, I would say. Secondly, we're all have been going through an unprecedented and really horrendous time. And it's really been, I think, shocking for all of us, because our status quo has just been thrown directly on its head. And it looks like at this point, for many countries, but still perhaps not for all of them, the number of cases, at least in the primary episode, have plateaued or are diminishing. But even so, there's still a huge number of patients who are suffering. And just recently in the United Kingdom, for example, I think yesterday, we still had 1,600 new cases confirmed. So it's, at least for the United Kingdom, it's still a very, very big issue. But on the other hand, like so many other of our colleagues around the world, we're seeing that our various countries are doing everything we can to regularize. In the UK, we started very gingerly with people going back to school on Monday. I'm not sure, Ahmed, I think that in your case, people have gone back to school a little bit more recently, longer. Is that true?
Yes, the situation in Finland is quite different. The numbers went down actually quite quickly, and today I guess we had 26. Yesterday it was about 12, and schools started 2 weeks ago, and the numbers went quite down, and as I said, quite quickly in comparison to our expectations in the beginning of the situation.
No, well, that's incredibly fortunate, and long may it last. And I hope that everyone else who's listening to you will have a similar experience in their own countries very, very soon. So, because there's such a difference from country to country, we're seeing that people have been going back at different times to work. And I believe you've actually told me that you've undertaken a Botox clinic or two in the intervening time. That hasn't happened in the UK, at least not to my knowledge yet. So all the different countries will be thinking differently about when they can actually go back. Did you say that Jonathan Fishman is actually on the line?
Yes.
Yeah, because Jonathan could probably tell us a little bit more about what's been happening here in London, because he just attended a meeting in our own trust, the outcome of which is going to be reopening the outpatients. Jonathan, are you there?
I'm here. Yes, I am. I mean, the problem we're having in the UK is, as John has mentioned, it's a very slow transition to try to restart a service that, we're not used to. I mean, what we have in mind is a much reduced service, face-to-face anyway, compared to what we're used to. We've been doing a lot of telephone consultations, and things within the hospital are just beginning to settle down. We've got huge waiting lists as well for patients for surgery that have been cancelled due to the effects of COVID. And those patients are pre-March patients, and we have patients beyond March that will require surgery as well at some point. But in terms of our outpatient appointments, we're having to space out our patients appropriately, so social distancing measures can be adhered to, so that rooms can be cleaned. And even with a positive pressure ventilation procedure room, which we're fortunate to have, we're only being told that we can see 2 patients per day for a face-to-face consultation, which would include a laryngoscopy examination. So essentially, we're having to really rigorously select out those patients that need to come to hospital, and the rest of the patients we're managing via remote telephone consultations. And the same applies to our surgery lists. The theatre capacity has been divided among different subspecialties, and we're being told that we can operate on 2 patients per day. So that's our current state of affairs. If I look at my waiting list as an example, if we carried on like that, it would take me 3 years to get through my pre-COVID waiting list.
Good Lord.
But that's the situation we're facing.
So one of the things that, Ahmed, that Jonathan and I did was we were sort of called upon in our laryngology group for our trust to look carefully, and with Ruth Epstein, the speech therapist, I don't know if Ruth's listening, to look at the entirety of the patient pathway. We started doing this I'd say about 8 weeks ago. And that's been really, really helpful to try to look from the beginning how the patient gets contacted, what should happen to the patient if we're thinking about bringing them in, when the patient comes to the hospital, what should happen to them at that point, what should be their pathway to us, when they actually come to the waiting room, what should be the requirements of the waiting room. Once they come through the waiting room, should we be separating the room where we take the history versus the room where we do the examination? In the room where we do the examination, what should we be using? What kind of equipment, what kind of protection should we have? And of course, we've gone very carefully. I'm sure in a minute you'll go through the document, going through the risks that, that phoniatricians and ENT and speech therapists are particularly at from the standpoint of aerosol generating procedures. So we've been looking at that in some details, and then looking onwards and what happens afterwards, what happens with the patient, how the rooms get cleaned. More recently, we've been looking at ventilation requirements for hospital rooms, which is of course a crucial issue from the standpoint of bringing patients into the rooms. And I don't think it's only in our country, I think around the world, these kind of questions have been asked. The CDC in America has gotten very involved as well, I think. So I think those are the kind of questions that have sort of led to the germination of us coming together as a group.
Yes.
And hopefully this document will, at least, it's as we'll all hear, those of us who are listening, it's only our opinions. It's not even our own organizations may have different opinions from those of us who have put it together. But at least hopefully what we're hoping for is that it will bring us all to the same place where we're basically working from the same hymn book, if you will, or from, and thinking about this in the same pathway. And by doing so, hopefully it will lead to more safety for our patients and for better patient care, and also more safety for the healthcareers.
That's what I totally agree with, and that's why I hope that right now you and the participants see the PDF that I'm sharing. I wonder if it is on the screen right now, but you should be. I hope that it's working. That you should be seeing the position statement.
It's visible.
Yeah, one of the important things is that this is based on what the co-authors see as the best way forward. But of course, in different places, in different hospitals, there will be differences. So these are a group of recommendations that we hope, or we think that they are the best way to deal with the situation if the peak is already crossed in a certain country. And these are not like a policy that should be enforced, but they are recommendations that can be taken, can be regarded, and can be dealt with. What I would like to also mention here is that you and all of the participants right now see the bullet points, and just I will go through them very quickly, and I would like to have the participant and panelists and the co-authors also commenting if they have ideas. I guess it went from the fact that we are experiencing mostly a confrontation with procedures that are aerosol generating in terms of the larynx, in terms of the procedures, the office procedures, and the procedures that are being done under general anesthesia. The other thing that is important, which is the second bullet point, is that even patients who are even asymptomatic patients who come to our clinic can be having the virus or the source of infection. And sometimes a patient can be tested and can be false negative. In other words, that the patient is positive, but the test is showing you that it is negative. And accordingly, they should be dealt with, bearing in mind that there is a possibility that you have an infected patient in front of you. One of the important things that is here as well is the fact that we need to move to telehealth whenever possible in terms of the diagnostics and in terms of the treatment. One of the things that we included also in this position statement is that many of the procedures in which we are doing aerosol generating situation, in which we are going through the mucosa, using laser, using shaver, it will be quite good to have the patient tested 2 to 3 days before the operation, followed by quarantine. With Temo Kinnery, Temo is the head of the laryngology section in our hospital. We have been doing this for the patients going for, like, for example, papilloma patients and patients going through office procedures, injections in the vocal folds and so on. And so far, it has been quite easy to have the patient going to the test 2 to 3 days before, then going after that to quarantine, where the patient is staying at home, and the first time the patient leaves home is to the operation theater on the day of the operation. These are the main bullet points, and when you go through the position statement as well, you will find a number of statements here dealing with how the otolaryngologist and those dealing with a laryngeal examination are at the forefront. And it seems that there's unfortunately a number of ENT surgeons who suffered from major complications from their exposure to positive patients, especially in the beginning when the pandemic started, or when the epidemic started, especially in China. Also, we have been going here in this part through the fact that infection is not only from the patient, but can be also from the surfaces in the examination room, from the air contamination that can happen when the patient is gagging or coughing, and accordingly, these are things that should be taken into account when we deal with patients in our department. In the same time in which we are aiming to open the departments to have the patients coming in, we should bear in mind that the viral load is mostly to be in the nasal cavity. And then we went in the introduction as well through the personal protective equipment, and we raised the fact that the FFP3 masks are the ones that, according to the literature, should be used. And this also include in addition to the face and eye protection, the caps, the gloves, and the fluid-resistant gown. One of the other things that we mentioned here, which was not in the first statement, is the good video examples by Marcus Hess that were published about 2 weeks ago. And we hope that this is providing good information for our colleagues. And then we also had our general points that are actually more or less showing again what were mentioned before in the abstract, in terms of the fact that we should test the patients going through operations 2 to 3 days before. We are still dealing with symptomatic patients. In other words, we are opening the elective procedures for symptomatic patients. Of course, it's a totally different story if you have a COVID positive patient in front of you and you know that the patient is COVID positive and that patient was tested. We also talked about the video endoscopy being preferred to the old times fibroscope in which you had to be very close to the patient with your eye on the fibroscope. From the beginning of the pandemic, we removed all of the spray anesthetics from our hospital, and we shifted to using soft cotton with lidocaine. And of course, the telehealth. I will stop here before continuing, and I would like to listen if there are any comments or questions from the panelists or the co-authors on these items.
Yes, Hamid? Yes?
Yes, Eugenia.
Yes, I want to comment also that sometimes, as we know, many of us, we go to the theaters or to the stage in order to examine a patient. And we didn't think about that. Of course, we can have all the preparation in order not to have the aerosol. But I don't know if somebody that we in Mexico are now under lockdown, 2 weeks more. But I don't know if some of the other colleagues have some experience going on the stage or in theater to examine one of the patients from voice, because we have to think that stage is all the time with aerosol because of singing and talking. I don't know if someone has some experience about that now in this COVID time.
Yes, I know what you exactly are asking about. Actually, Eugenia came to mention something that is not in the position statement at all, which is a relatively small part of what we're dealing with, but it's important as well. You mean probably the situation in which in Mexico you are going to examine a patient or actually a singer in a concert on the stage, which
yes, sometimes
is, yeah.
Not now, but I mean, I want to hear the proposals from everybody. What do they think about that?
I have to admit that I guess we didn't think about it, and I know that Bernhard Richter in Germany, they have been working on a statement regarding the concerts and regarding the different events in which at certain places and at certain countries, it may be even common to have a laryngologist or a phoniatrician in the place of the concert doing the examination. But that's very true. It's quite possible that it's in a singing situation, the singer is producing more aerosols in comparison to someone who is just speaking.
Yeah, that's right. That's right. Anyway, another situation is when you have to go, I don't know in the other countries, but sometimes in Mexico, we do need to go to the house of the patient because it's a completely unable patient to come to us. So perhaps we have to think about that. And in COMED, we are thinking about this stage aerosol.
Yeah. And right now, what we have been trying to focus on is the common situation of the patient coming to the office examination. Like, for example, when we have the routine office examination that is being done to a patient. And what we recommended in our position statement is to have the full personal protective equipment, including the FFP3, including the masks during the examination of asymptomatic patients. And of course, this is not only for the common voice patients coming to our clinic, but also for the patients coming for tracheostomy tube changes or adjustment of voice prostheses, bearing in mind the fact that the patients will be probably coughing, and this is not uncommon at all when the patient is coming to our office. One of the other things is what John Robin talked about in the beginning is that we have been doing the office procedures. We stopped in March, I guess also in April. I mean, I'm talking about Helsinki, and we are now continuing with the office procedures. And our recommendation is to have the personal protection. What we do right now is that we are testing these patients 2 to 3 days prior to the operation, and such operations include vocal fold augmentation, other procedures done through a channel fibroscope, and ideally, such operations should be performed in a ventilated, low pressurized rooms. But I guess such ventilation or such pressurized rooms are not necessarily available everywhere. I'm not sure if they are available in different other countries. I know that Jonathan and John, from what I heard from you, you have been talking about this recently in the UK.
Yes, I'm sorry, I lost you for a moment or two there, Ahmed. I had a problem with my connection. I am back though. Oh, absolutely. Before I get to the ventilation, which I think is something that we do need to talk about extensively, I'd like to pick up on what Eugenia had mentioned about the choirs and about the West End theaters. In London, the West End is closed. In New York, of course, things are closed. And I think in most major opera houses around the world right now, things are closed. So I think those kind of issues, Eugenia, that you were particularly talking about, I don't think we're going to be in a position to actually really consider those in any great detail for probably for months. That would be my guess. I think until we know for certain that we've seen the back of this virus, my personal recommendation would be not to go backstage with a flexible endoscope, which might not have been my recommendation 8 or 12 months ago. Similarly, from the standpoint of going to someone's house, I don't think anyone, certainly in the United Kingdom, is, from an ENT perspective, is undertaking house calls. If you were to undertake a house call, I think you'd have to be so careful with the equipment that you brought and the protective, the whole methodology of how you protect yourself. I don't know if that's a helpful answer from the standpoint of your specific questions.
Yes, I think you are right, but I am thinking a little bit about the future. For example, in Vienna, in Austria, they are opening now theaters and opera houses. Of course, with many hygiene measurements like masks for the people and things like that. But I was thinking more about the future, September, October. And you are right, we cannot take now house calls, but in the future, mainly in winter, I am very concerned about winter because winter we will not have, I think, a vaccine or a specific treatment, and we have to deal with these problems because theaters have to open sometime. But you are right, dear John.
Well, it would be, in fact, Ahmed, it would be interesting in the next variant to the next version of the talk to perhaps ask Yosef Shlomo Khatir, who's so involved in Salzburg with, I mean, he spends his summers with the Opera House, basically giving all of his time, and he effectively lives with them to get his views on specifically Eugenia's thoughts about going backstage at the time of COVID, because they are obviously questions that are extremely germane to us.
Yes, yes, that's why
extremely germane. But I think it's at this moment in time, it's premature for us to be looking into them in any specific detail.
Yes.
But I would have said that as we go on to our next, because what's going to happen, this isn't a static situation. Ahmed, I'm sure, could tell us how things have changed from the first discussions that we held back in early to mid-April, that led to the website suggestions versus the discussions that we've had now. And I'm sure that will continue as we go on to the next level at sometime in probably late June when we come out with our next proposals, etc. This is still very much a fluid phenomenon. Hopefully, we won't see secondary recurrences of the disease.
Yes, we changed the situation quite. I would say totally that in the beginning we were saying for a total shutdown of all of the fibroscope examinations except the one that are intended for patients with suspicion of cancer, and then we moved to a total different situation right now in which we are thinking that patients that we deferred to a later date, they didn't disappear, they are still there. And we have to open our offices for them and our operation rooms as well. And I guess this is a situation that is still developing. Probably what we are going to see is some kind of a plateau situation that is going to take months or even years. I would go also to the laryngeal procedures.
And may I interrupt you?
Yes.
There are some interesting comments and questions in the question and answers. Can
yes,
you see?
we now I see that there is a question about community dysphagia services, and a question about the most rehabilitation interventions from phoniatricians, speech therapists, or AGB. That's very. These are very good questions. I would do this. That I will go quickly through this and to the swallowing part, and then we get to this part quite quickly. Because I would like to finish the voice and laryngeal procedures. One of the things that we also discussed is the laryngeal procedures and our general anesthesia. That we aim to take the asymptomatic patients to our operation room, and they are tested 2-3 days before. And of course, this should not be a reason to delay cases in which you have a malignancy that you need to have for one reason or another immediately or within a couple of days, and you're not sure if the test is going to come or not, or cases in which there is a risk to the airway itself. Such cases should not be delayed. One of the other things you'll see here is that we have been talking about the different types of operations or the different types of anesthesia. And one of the good things to bear in mind is that when you are using, for example, jet ventilation, then you have a higher flow of air going in and out. And one good option is the flow control ventilation, which you have this very small tube, and it's a cuffed one. And that can be a good alternative to jet ventilation in certain circumstances in which, for example, you're thinking about vocal fold augmentation and you have been using jet ventilation before. One of the other things is that surgical suction devices, they should be also equipped with filtration systems with greater than 99% efficiency for the removal of 0.1 nanometer particles. So we are aiming as much as possible to decrease the risk of infection. Testing has been mentioned before, and the fact that there is also a risk of false negative results. And telehealth has been discussed. And then we talked in the beginning that right now, or for about 1 month and a half, we have been doing Botox injections, because in the Botox, when you go through the cricothyroid, and if you are not injecting anesthesia in the lumen, then you are staying all the time below the mucosa. So in other words, you will not be puncturing the mucosa, and you are not expected to have a coughing patient in front of you. In patients in which we are going through the lumen to the posterior cricoarytenoid, it's a different situation. The patient will be coughing for sure, and then a test 2 to 3 days before the procedure should be done. And the same goes for situations which you are going transoral or transtracheal, and situation which you are using this channel fibroscope. And now we get to the nice questions that we have.
Before we get to swallow, while you're talking about the botulinum injections, because that'll be an area that's going to be so much of interest to so many of our members. Are you wearing an FP3 mask when you're doing it? Well, we haven't gone back to doing them yet. We probably are going to go back in a couple of weeks. Can you tell us what your PPE approach is to these patients?
We have a different line in our hospital. So what I'm doing in my clinic is that we have got our hold on the FFP masks. So what I do is that I'm having it, and I'm having the visor, the shield in front of it. And the idea from the shield, in my opinion, is that it's much better in comparison to the glasses, because in this situation, the FFP masks can be worn for a longer time. So you don't have to change it if the patient is coughing. Hopefully, this is going to be examined, because some of the procedures that we do, there is a little bit of controversy if they are aerosol producing or not. In other words, if you have an examination, a fibroscopy for the patient with a voice problem, and the patient is coughing, and another patient is not, is the patient for which you are doing it without coughing and going through a mask on the patient, for example, with a small hole in it, is this aerosol producing?
I would have said we have to assume that it is.
We have. But it's actually, it was never studied in a clinical situation.
No, and again, that leads to the question: are you having your patients wearing masks? And if so, what type of mask are your patients wearing? Because we know that if you just take a surgical mask that you can buy off the street that fits around your ears, that's basically an equivalent of an FP1 or less, that because it's loose fitting, really what it's doing is it's protecting the patient from probably from their doctor coughing on them, but it's not really protecting the personnel in the room, because when they cough, all of the particles come out from both sides. But nonetheless, it probably will control some of the large particles, not the smaller particles. So what are you doing from the standpoint of your Botox injections in particular? Are your patients wearing a mask as well?
Yeah, the patients, they are wearing a surgical mask in my situation. And all of these patients, what we do is that we deal with them, we call them a few days before, we check on what we will be doing. We kind of, with Botox patients, you usually have a patient who has been coming to you for a longer time. So you usually discuss with the patient when the patient is there in the operation, in the office, what kind of dose that you will be using for him, how many units you will be injecting. Right now, what I did is that I shifted this to be a few days before the injection. So the idea is to limit the time of the patient as much as possible in the office. So the patient is coming on the set time. He will be having the patient, or she will be having the mask on, and then she goes inside, and then you don't talk about the number of units you are doing, because you have been talking about that on the phone, and you're just doing the injection. And I would say that having the most experienced clinician doing the injection will result in quite quick procedure for the patient. So we are talking about normally a couple of minutes.
Mm-hmm. And another thing that certainly Jonathan and I have been looking at is, and I think many of us have, is having one room for speaking to the patient and getting the consent, and then one room that only has the procedure undertaken as part of the pathway. Because that very much may make it easier to clean the rooms and allow for more efficient patient passage through your system.
That's a very good idea. Maybe the fact that we are able to do that on the phone is saving us from the need to have 2 different rooms. And here comes also the idea of the telehealth, or the communication with the patient, in which you can go through the medical history and you can go through the different issues related to the procedure before the procedure on the phone. So you're reducing the time the patient is spending in the hospital and reducing the time the patient is spending in the procedure itself.
So both of those are aiming at reducing time that isn't being used specifically for your procedure, which makes tremendous sense.
Yes, yes, of course.
One of the questions that came here is related to the testing as well. Is, do we need to test COVID in both children and adults? And what about parents who come into wards endoscopies together with their kids? Do we have, because we didn't specify that in our position statement. We didn't talk about children coming for endoscopies.
No, but by and large, I would have thought, Ahmed, that you're not actually doing interventions on the children that involve breaking through the mucosal barriers in the office. Is that not your experience? If you have a child, I mean, we don't tend to have children that we operate on in that fashion. The most that, at least in my practice, I do is just a flexible nasendoscopy, maybe if I'm lucky with a stroboscopy on a small child. Jonathan, if you're there, you run a pediatric clinic. Do you have any thoughts about that?
Yeah, I mean, the pediatric patients are not easy. I mean, I've seen one pediatric patient in the clinic already, and just trying to keep a mask on a child is not an easy feat in its own right. I mean, the difficulties we're encountering in the UK is lack of capacity for testing for routine clinics. So we're testing everyone prior to surgery, but we haven't exactly established whether patients are going to get tested before routine clinic laryngoscopy examinations. Certainly our sort of national body, ENT UK, has felt that it's not going to be feasible to test every patient prior to a clinic appointment.
And Miki brings up a very interesting question about management of papilloma in children. I don't treat children with papilloma, so I'm not the right person perhaps to pick up on this. Timo, I don't know if you do. Is anyone actually undertaking interventions for papilloma with a child awake? I would have thought that these children would be taken care of in the operating theater, and in our facility, at least, all patients who are being operated upon, unless it's an emergent situation and you're not able to, they are having testing done. And I think that's quite a sensible thing to do. And
Papilloma is a good question. I would say that papilloma patients are one of the first patients that we need to operate on in these cases. Of course, the cancer on malignancy is of course naturally a case that we need to operate, but the papillomas comes maybe the next. We do have very few pediatric papillomas, so I think we haven't operated any of them yet during this time, but I would expect one of them in a few months next or during the summer maybe.
So in our clinic, the papilloma children, we send them to the hospital. We go to the hospital, but we do make many children examinations. Of course, since March that we have lockdown in Mexico, we have not had these children examinations. Usually we use flexible for the nose, and also we use a rigid 70 degrees for the mouth. So I was thinking about what John said and the audience, that perhaps it was not a bad idea to have a curtain before the child with a small space for us to get into the mouth of the child. We have to think about that, because it is not easy for a child to wear a mask during the examination. We have children since 3 years old, usually, but now in this time we have not had, but we have to prevent all this aerosol from the children.
Eugenia, that brings up a very interesting point that we haven't really touched upon, which is rigid video laryngoscopy. We've mainly focused on flexible video laryngoscopy. And my own practice with my professional voice users, with my singers, I would say probably heretofore, say a year ago, 75 to 85 or maybe even higher percentage, I would examine their larynx with rigid video laryngoscopy. But my guess, I may be wrong, but my best guess is until this illness has petered out in the population, my personal practice is going to change, and I'm going to just use flexible nasendoscopy for these patients. Because to examine someone with a rigid scope, with or without a camera, you have to hold their tongue, you have to be really face to face, very, very close to maybe within 10 centimeters. And I think even though you're avoiding the nose, you're certainly converting it into a definite aerosol generating procedure. That's been my own thinking as I've been approaching this. Ahmed, I don't know if you use or Timo, if you use rigid scopes and if you've been using them since you've gone back to work on your patients.
Yeah, actually, for some of the patients that I have, that I know that they will not be gagging with rigid endoscopes, I have been using them. And yeah.
Since we have had the high definition scopes, I've practically changed to the flexible endoscope in all cases. So I actually haven't used too much rigid scope during the last 2 years. So we don't, in the laryngology department, we use them very seldom, but I know that phoniatricians are, because of the better
better optics
and the slow motion image is much better with the rigid scope in our case. So I would guess that phoniatricians are more fond of that.
Well, yeah, for me, I think this is going to lead to a substantive change in practice.
Yeah, also by children, mainly in my population, they don't feel very comfortable with nose. With rigid endoscope, what I do, I put some kind of sweet, with like a tablet with a little bit sweet, and this sweet is bigger than the endoscope. So I put inside the mouth both at the same time. So the child, they are very happy because they are tasting the sweet, not the endoscope. But anyway, sometimes I do need to use some lidocaine or anesthetic in order to not to have the gag.
One of the, I'll take we have many questions that came out, and I would like to give some attention to them as well. How many clinical stuff in the particular office procedures, for example, Botox injection? In my experience, what we have been doing is that we have one nurse, we have one clinical neurophysiologist, and we have the clinician doing the injection. And usually we have another one, a colleague who is in the back for a little bit, doing the work was writing the patient's papers, and during the procedure. So what we are aiming to do is to have it as fast as possible. So right now it has been like 4 persons, 3 to 4 persons in the buttocks injection or in the vocal fold augmentation, transoral or transcutaneous. A very good question came also, and I would like to forward this to all of the colleagues here. Will pre-surgery, pre-endoscopy for COVID stay in ENT? What do you think about this?
Ahmed, would you repeat the question? Will
pre-surgery, or pre-endoscopy testing for COVID-19 stay in ENT?
In other words, who will do the testing? I'm not sure I quite understand what the
In other words, who will be doing the testing in the future for our patients coming for surgery or for office procedures? Will it be the mainstay in ENT in the future?
That's an interesting question. Will the GP do the testing? Will the testing be done in the hospital in the morning and then they come in the afternoon for the procedure? Or hopefully, as we get slicker with our testing, we'll be able to turn around testing results quicker, which will make it easier for the patients.
I mean, there is certainly point of care testing facilities available when we're able to get these, but I think currently pre-COVID, we routinely screen patients for MRSA. I don't know if you call it MRSA in different countries, but I imagine that all patients will continue to be screened in some form until we have some form of vaccine, certainly for the surgery patients.
Yeah, I do agree with all of you because I think it's very important, just as we do sometimes bacteriological tests. But in this case, I would advise at least 1 year to make all the time for surgery, not for examinations, but for surgery. And I do agree we have to talk with the patient before in order to follow up where were they the last 14 days, mainly in Mexico, that we are in a very bad situation now.
Yes, our ENT UK, our mother organization in the UK, has stated that they don't feel that we need to do routine testing for outpatients for if they don't involve putting needles through mucous membranes. They feel that that these procedures, by and large, if they're asymptomatic, don't need to be undertaken, and they're limiting it for theatre. That hasn't necessarily been my opinion, but it's been the opinion of ENT UK. And those of us in the UK, I think, in ENT will abide by this.
Yes, and that's what I was saying in the beginning, that in our different hospitals, we may have our differences with the way in which the hospital is working. And it's very important to bear in mind that for the attendees and for the panelists as well, that what we have here in the position statement does not represent what is happening in each one of the co-authors' hospital. It can be different, and I'm sure there are differences. There are differences in my hospital, which is going for even what I say less strict than what is here in the position statement on a huge level. And there are many differences. You will find that even in the same hospital, you can have some differences between different polyclinics and different departments. We have also on the swallowing, and Haldun would like to say something.
Before continuing with swallowing, it was a great question because we just tried to define some principles in that paper. We will be facing different situations, which means in even best predictions, they say that only the 2% of the population is now infected. I mean, if we have as much asymptomatic carriers that we couldn't recognize yet, for my country, for example, it's just 2% of the patients, 2% of the population is just infected. It is, Istanbul is the center of the pandemic now in Turkey. and it's predicted that only just 6.5% of the population is infected. So we will learn to live with that disease if it doesn't go into a nice mutation for us. So we will be thinking even all asymptomatic patients that we face as asymptomatic carriers. So we will be needing to make those tests before we are making some invasive procedures, I think. Not for all examinations, but all invasive procedures under local in office or under general in EOR.
So again, it looks to me that as we learn more about this disease, our own recommendations may well change.
Sure.
And that's the beauty of this group that we've got, that we all will continue to be speaking to each other and as things progress.
Yeah,
Exactly.
another issue that I think is interesting for us, because we are talking to the patients, perhaps not so much, not so long, but we have experienced some voice disorders by speaking with the mask. I don't know if somebody has comments.
That's a really interesting question, Eugenia. And in fact, Ruth Epstein and I have just been speaking with our anesthetists about doing some research or checking what their voices are like before and after a session
Yes.
to try to quantify that. That might be something that would be a useful thing for the UEP as a group to look to do, because it would be quite easy.
One of the things that we also have been talking about recently, there is actually research starting in my department about this, which is the effect of distance teaching on the teachers' voices, which is something new that we didn't experience before. That at some time, all of the teachers in Finland, they were teaching online. And some of them obviously had some voice problems, and some of them said the voice problems got better. So we were interested in this, so we are checking on it. Now we'll go to the swallowing part, because this is a very important part, because when it comes to swallowing, and right now our recommendation is that we prefer to have the fees reduced in time. In order to lessen the time that the patient is spending, and also to have the time of the actual procedures to be short. And accordingly, we have been focusing mainly on the patients who have the main priority, like patients that we are considering to have big, for them, or nasogastric tube, and we at some time we will have to deal with the other patients that are less, let me say that they are not on the top of the priority. They are not going anywhere, and in the end they will be coming to our departments. We have been talking about this, and we have been talking about the role of telehealth, and that it's very good for the COVID positive patients with swallowing problems, that they should be managed through indirect assessment, if it is possible, by remote telehealth and diagnostics. I wonder if we have a very good group of swallowing experts as well here. So I wonder if they would like to say something about this. I'm not sure if Farhat, Sevilla, Christina, do you have Mika? Do you have comments?
Hello, Ahmed. Hello, all. I'm happy to be here with you. Not a comment, just emphasizing of what is written here and what we have agreed, and repeating again what you have mentioned and my colleagues mentioned, that it is not necessary that all of these recommendations to be applicable or to be applied for every single physician at his or her area, because you know some countries now are rising, some countries are going down, some countries are at the peak. So maybe some of these recommendations may apply for some and may not apply for others. But we'll take the best of these recommendations. If we can say it would be like guidelines or something like this. For swallowing, you remember when we talked about earlier about the swallowing issue, and one of the most important and critical cases that we are dealing with in our specialty that put us at high risk of being infected. So I'll tell you that our experience in my institute. I sat with my team, and we started to brainstorm about all the cases, all the possible cases that we have faced all over almost 12 or previous 12 or 13 years. The possible scenarios, I mean, the possible histories. And we discovered that we can categorize those patients as mild, moderate, severe. And after a long discussion, we agreed that if we can exclude the mild and severe cases from being seen, I mean the mild cases, I mean by mild cases that the patients could be safe for some consistencies, but not for other consistencies like this. And the severe cases, for example, in the ICU with very low GCS, those categories, either the mild or severe, they are not necessitating urgent assessment, either by bedside or instrumental assessment. So by excluding those categories, and by the way, if we exclude them, we can do some screening over phone, and we started to do so for a lot of cases. And it succeeded to manage, honestly, a lot of patients in this way. The team is being consulted through phone, and we are explaining to the caregivers what they can do exactly, how they can do the screening, very simple screening protocol, so we can decide whether those patients is at risk of being fed orally, or they could be fed through the mouth. The moderate category, those ones that we can do bedside assessment by the team, and still not all of them will go through instrumental assessment. Some of those moderate cases could be dealt with by bedside assessment only, and some of them could be by instrumental. If we will decide to go for instrumental assessment, of course, modified barium swallow video fluoroscopy is much preferred than FEES, at least for the time being, because, you know, although there is still risk for exposure for radiation, but for the sake of this infection and pandemia, we prefer more to do video fluoroscopy if possible for the patient to go to the fluoroscopy room. If not, we'll do the FEES with the precautions and with the full PPE. This is what we are doing now in my institute. I hope I can help anyone to answer any question or any.
This is actually very good, because Sofia is in Slovakia with Miro, and we had a very nice article published in Dysphagia on the post-intubation, in Dysphagia journal on post-intubation dysphagia among COVID-19 patients. And I guess it's probably the first article that is addressing this problem, and it's a review one. And I don't think that in the literature there has been any previous one as a review article going through all of the studies and all of the information so far. And these patients, they will come to us sooner or later.
Yes, exactly. Not later, sooner. They will come sooner. Very soon after extubation. Yeah, most of those patients are experiencing some sort of dysphagia because if you know the affection of the sensation after extubation. After what I have read before, I don't recall the article. Actually, after 48 to 72 hours of intubation, the risk of dysphagia is doubled. So by each day you are doubling the risk or possibility of having some sort of swallowing problem for the patient. So can you imagine if a patient is intubated for 10 days or 2 weeks or something? Yeah, you can expect how stressful will be the case of the patient. As
Sophia, you had a comment, but your your mic was off. Actually, right now we are not hearing you.
Still off.
No? No? I don't know what is the problem. It's we are not hearing you. I guess there is a problem with your mic.
Yeah.
While you try to fix it, maybe Christina, would you like to comment on this?
Yes. Do you hear me?
Yeah.
Okay. Okay. Yes, I totally agree. We do the fees all the time in full personal protection. We don't do the video fluoroscopy very much because I think the way the patient is in the clinic is the time he is in the clinic is important, and it would be much longer if we do video fluoroscopy, but that's our German problem, our Hamburg problem. I think we shouldn't shorten the examination time too much because the fees, we use some informations and we should examine the patient until we have all informations we have to know for the therapists, and not to do so many examinations. I would add this. But from my point of view, it's not more dangerous than a voice patient to examine a dysphagia patient. So I totally agree with the chapter in the statement paper, position paper. So if you have some more questions, how we do it in detail.
Yeah,
but
also, if we can say that if we are going to do instrumental assessment, especially fees, we can do it a modified version of fees. I mean, not to not conduct all the protocol for fees for all consistencies and volume. Do you agree with me in this?
Yes, of course.
Okay, this is good.
One of the other questions that we have also regarding swallowing, and I'll go straight. What about the sometimes that we have speech service doing community dysphagia services? We have sometimes speech service doing what we call here in Finland rehabilitation phase, in which they are having the patient, giving the biofeedback, trying different consistencies, trying different head positions while in the fees. And actually, this is even longer than the diagnostic one. Right now, we are not doing it, and I guess based on the fact that we are mostly dealing with the hard patients, and we're mostly trying to listen the time of the fees examination. Do you think that this comes at the second priority, or what do you think about this?
Yeah, I think we have to agree that the rationale for fees will be totally different from the original rationale of fee that we learned before. If we are going to do fees for a patient now with a swallowing problem, I just need to know is he or she safe for some consistencies, for certain volumes or not. Yes or no. I think it will be very long for me to test the patient and to give the patient some instructions or position and to measure the effectiveness of these positions and maneuvers. I think no time for this. We have to minimize the time as much as possible. That's why we started to do these modified fees. So what is the way to do modified fees and to add more time for the examination to put some exercises or some positions like this?
Yes. Do we have other comments on the swallowing?
Yeah, I have got one comment. I'm not totally the same opinion because I think the rehabilitation is very important for the person because of its mortality and morbidity and so on. We all know this about dysphagia. But I think the therapist should exercise with the patient without fees and then should do the fees in in longer intervals. So we shouldn't look at the exercises under FEES, but we should do the FEES in a few weeks between each new phase of rehabilitation. So I think this is important too.
Yes, and this is one good idea as well, because if the situation right now in for example in the UK was the huge number of patients still, or people still being infected, when the number goes down, then probably we will be having much looser, what is the right word for that? That we will be having less restrictions in terms of the services, in terms of what we are doing. Probably in the future, we will have some quick smears being taken for the patient while the patient is coming to the hospital, or while the patient is coming for rehabilitation services, for example. So this is probably going to have an effect on this.
Ahmed, I would say, if I may, that this kind of debate is exactly what this webinar is about.
Yeah.
I mean, it's fabulous to have two different opinions, both of whom are trying to do what's best for the patient, while at the same time maintaining safety. And the next time we hold this webinar, which we'll probably do this again, I would have said in 6 weeks, this exact discussion, our entire philosophy may have shifted again. So that's one of the reasons why I think it's such a brilliant idea that you've brought this together.
And right now I see that, for example, Professor Wafa Dieter from Germany, she wrote that they hardly do fluoroscopies in Würzburg, and they are doing phase for almost all swallowing patients when necessary, and they use complete protection over there. So they are not, they hardly do the fluoroscopies. We have also another comment that the from Belgium, Yuri Marin is currently conducting an acoustical analysis of the voice with and without mask, which was something that we were talking about. So it's very interesting to know about this. We have a test right now. I'm sorry, we have a research right now starting in Helsinki, where we have actually a huge one, which we have a virology group going to examine the different procedures that we are doing in terms of their aerosol producing situation. So we'll be going through the phase, through the examination with the fibroscope, with the rigid scope through the mouse. So we are trying to find the kind of aerosol producing procedures and to what extent they are aerosol producing procedures. And also with laser, with shaver in the general anesthesia in the operation room. So I guess this is, hopefully we'll be able to have some results in the beginning of autumn that we can tell about the kind of findings that, that we have in terms of these procedures. And I guess it will have an effect on our way of working.
Yes, and may I say something that we talked about at the beginning, and this is the ventilation and the purification, because in some of our examination rooms, we can have a purifier for the particles, not for SARS-CoV-2, but for the particles. And also the ventilation of the examination room, it's very important. Of course, not under general anesthesia, but in the examination room. So we have to pay some attention about it. I don't know, Ahmed, if in Finland you have been looking about the ventilation, what is better? Because I have been trying different ventilations and with the purifier of the particles to see how is the particles load. We do know this is not the SARS-CoV-2, but we do have another kind of environment. The better is for us also in order to have a better load from particles. I don't know if you have some experience about that, Ahmed.
What we have, and this is what we have with TEMO, is that right now when we do the procedures under general anesthesia, we have our operation room low pressurized, and this is one of the things that we hope it will be helpful. As far as we know, it should be the right way of doing things. Of course, I have also to mention that it is low pressurized, and the patients, the elective ones, are going through the testing 2 days before the operation. So it's in other words, and we are of course using the FFP masks while we are doing the operations under general anesthesia. So it should be safe. Or what Tim would like to add?
I would like to add just a small detail that was not included earlier, considering the low pressure in the operating theater. One could even introduce the low pressure in the larynx itself in all the operations that are producing the risk. And this is the using of the vacuum, the smoke evacuator kind of vacuum, even in debrider operations, where you produce the aerosols. You can actually suction them directly from the larynx using the smoke evacuator always, not only in the laser, but in any case. And you could even introduce this to the working channel while you are doing an endoscopy. So you might produce a negative pressure to the larynx during the operations, of course, including to the negative pressure of the operating theater itself. This is just a small detail.
Ahmed, can I pick up on that? Because
yeah.
We're so used when we do papilloma cases to have devices that suction out debris, because so many of us already have been working with open airway systems, if we use jet ventilation or Thrive or what have you. And there's no question that in the operating theater, any type of devices that you have that may remove particles from the air have to be beneficial and really must be used. It still doesn't change it from being an aerosol.
I guess we, John, I'm not sure if you're there.
Oh, he's gone.
Yes, yes, we lost the connection with John. Of course, John probably was referring to the fact that it will be also good to have a closed system while we are doing the suction, and possibly a filter as well added to the suction system. I'm not sure if Jonathan would like to add to this.
Sorry, it just broke up a bit. Can you just repeat the question?
That when you are doing the suction, you would be aiming to have, if possible, a closed system, and also to have a filter.
Oh, absolutely. I mean, that's what we're doing now. So, for example, all our tracheostomy patients are having closed inline suction, and we're using the HME, the anesthetic HME filters that allow filtering of viral particles to high efficiencies. So yes, definitely.
Yeah, as suction being aerosol reducing, so.
Oh, absolutely, 100%, yeah.
Yeah.
Just to put it into perspective as well, the otologists who we work alongside are doing the same for microsuction clearance, because there are concerns about the middle ear as well.
Mm-hmm.
Exactly. And Sophia, I'm not sure, did you get to the mic? No? No, it's not working yet. Getting back to the last part of the position statement, we have here some information on speech and language, and we have been talking about that in places where we have speech and language included in our departments. It will be very good to limit the time spent by the child. So you can also apply telehealth that you will be the speech and language service, for example, will be calling the family and trying to have as much as possible from the questionnaires being done online. And then some of the assessments cannot be done over the telephone, then the child will be there. And accordingly, we should be aiming to limit the number of the parents with the children. Right now we have John back.
I'm sorry, Ahmed. My internet suddenly went down. Goodness only knows why. And I was talking, particularly to Eugenio, about ventilate the CDC in Washington. And what they say for a treatment run, you require 6 air changes to remove about 99% of your particles. Of course, one issue is whether or not you have a window that opens or not. Now, the room that Jonathan and I are going to be using for our procedures rooms actually will have about 16 air changes per hour. But if you're in just a plain treatment room with a window open, it takes about 45 or 46 minutes for 99% efficiency and 69 minutes for 99.9% efficiency of removal of particulate matter. So those are really useful figures to keep in the back of your mind.
Exactly. And I went very quickly through the speech and language, and I have really to apologize for the fact that it's very very short. I should have been trying to have a more detailed one, and I already received very good comments, and I will forward them to the co-authors from Wafa from Germany and from Rehab in the UK, and they are very good ones. And I'm sure that we will try to improve this part. Same goes with pediatric cardiology, which is one part that has been very important. We had Catherine Newman. Unfortunately, I don't see her right now with us, but we have been talking that screening of the newborn should be maintained because this is a very vital thing, and that the face-to-face clinical time between the clinician and the child in pediatric radiology should be reduced with possible no waiting time. We also included in the position statement 3 issues that, in my opinion, they are very important, and I guess you agree with that. The disinfection and how it is important, and the fact that disposable equipment should be preferred or should be used whenever possible. The reimbursement, that we think that in countries where telehealth was not compensated, it should be compensated, because in this way we are lessening the risk of infection and trying to have the pandemic to go down. I'm very thankful because this has been brought forward by Mieke Merman from Belgium, who brought this forward. And also she brought forward the idea of the confidentiality, that it's paramount that while we're using telehealth, we should be also making sure that the general data protection regulations in the EU are respected and are dealt with accordingly. In other words, to make sure that the type of communication that we are having with the patient online is safe. I wonder if Mieke would like to comment on this.
Okay, can you hear me, everyone?
Yes.
Yes.
Yes, we have been studying some regulatory and legislations about telehealth in Europe and abroad. And we found that there were some really big issues for being conform with these legislations and regulations. And that is next to the GDPR, which you all know, is it about security and safety of remote healthcare delivery. And that is some prerequisites, which are, of course, the privacy in regard to data breaches and data leaks. So the connection must be end-to-end encrypted, must be performed with an up-to-date browser, must have a two-factor authentication, and so on and so on. Then there is also an issue of availability. So a good telehealth tool should be available ideally at all times and in all places, which means again that you should have a very good browser up to date, a very good internet connection, of course, and also that the tool is available on PC, tablet, and smartphone. So these are all things I have studied, I have investigated, which are quite important to have a robust means of delivering healthcare in a remote way. And another thing I want to raise is that there is a bit a misunderstanding about the definition of telehealth. I think so, I believe so personally, because it is more than only video chatting and consultations. It is more, I see it more as a management, health management, which means that you should be able to gain insight into the patient's value by questioning the patient, that the patient should be able to train independently and that he can be guided by the caregiver. So it is really a coaching strategy. And then of course, if you also have, these are two forms of asynchronous remote care. And then if you combine it with a synchronous form of remote care, which is a video chat model, which is safe and secure, then you have a complete healthcare management possibility remotely. So I don't know if there are any questions about that, about telehealth. I can go on for longer than 5 minutes.
Miki, I have a couple of queries for you about visualization. What's the state of the art in being able to visualize orifices, ears, noses, mouths, larynxes with remote health? Are you aware of any devices that allow this?
Actually, John, I am now, as an adjacent business, developing a small device of my own for connecting to a web-based tool, and small device for looking at the back of the tongue, behind the corner, at the vocal folds, and at the upper esophageal sphincter, the pharynx. But just not so in detail as the ENT specialists, because we do not want to compete with them, but it's only a device for general practitioners, so they can make a little bit the big diagnostic, differential diagnostics. Mm-hmm. And it all depends. It all depends if you talk about what are the prerequisites for such visualizations, for such videos. It all depends on data transfer, because the more pixels you have, the more data transfer you have, the more time it takes, the more broadband you need for your internet connection. So there are countries with an unstable internet connection, and then you do not want to transfer huge files over the internet. So it is really a not easy equilibrium. A solution is, of course, that you first record a diagnostic imaging or file, and that you compile it in a video, compress it, and then send it over in an MP4 format or whatever.
It's a little bit, I'm sorry, Ahmed, outside of the remit of this discussion, but it's incredibly important as we're heading more and more towards telehealth.
Mm-hmm.
You know, I have to tell this, that it was very interesting that when this started and we all in our hospital shifted to online meetings and using Teams and so on, then suddenly we started to experience and to get emails from the IT department that try to limit sometime the different applications that will be using the internet. And this was the first time ever that they tell us about the internet speed going down because of the usage. And actually it went a little bit down for some time, but it's And we witnessed that on different online applications in our mobiles back in March and April, and this was something quite new, that they got slower. And so it's true about bandwidth. It's true about the fact that there is a new shift in the way we're dealing with the health services, and no one knows how things will look like in the next few months. One of the things that I would like to recommend is that we should be taking the recommendations or the ideas coming from this discussion. We should be also taking the new recommendations coming coming in the literature, and we should be updating our position statement, because I guess the situation 1 month, 2 months from now is going to be different. We are quite lucky that we submitted our article to our position statement to Journal of Laryngology and Otology, and I have the good news that we received some minor corrections, and hopefully it will go through. And in my opinion, it's a huge step forward that we are able to find a way in which we all try to agree on how things should work in the future. Because in the end, even in the UK, it will slow down, the number are going to go down, and you will be opening. And then, while we are already open right now, so we can tell you how we are dealing with things from our opinion. You can tell us also how you are dealing with things right now. And I guess it's a huge and very good exchange. It's a huge forum and excellent way of exchanging of knowledge and information.
Again, Ahmed, congratulations on this tremendous work.
Thanks to you. Right now, we scheduled 1 hour for this. It's 1.5 hours. I would like to know if you have any final comments. Do we have any final things to say before we close?
Yes, I would like to say that I am very concerned about the 30% of false negatives in PCR test. Perhaps somebody can give me their opinion. In Mexico, like in China or in Germany, they have 30% of false negative. So for the patients with surgery, that we make surgery, and we ask for PCR test, and 30% is false negative. So I think we have to think about that. I don't know if somebody has another comment.
Well, you're absolutely right, Yanni. We have to, every single patient that we operate on, we have to assume is positive right now.
So what
and even if they come to you completely asymptomatically, there's studies out that came out last month that show that there's 2.5 to 3 days if they're infected with the disease when they're able to transmit it before they have any symptoms. So it's just something we have to keep in mind as we're seeing patients.
So what I am doing at the moment, I am not doing surgery, but what I am thinking about the end of June or July that I can do again surgery is that I'm going to test 5 days before surgery and 5 days after they began to be in their work, in their job, or with another kind of persons, not only with the family. Because as we know, we can also do IgM and IgG, but it all depends on the days. Well, it was just a comment. And congratulations, dear Ahmed. This is a wonderful, wonderful work. And to everybody that comment and said all the things and are now together with us.
I totally agree with you that it's a huge problem, because the false negative, it's affected by the test itself, and it is also affected by how the test was taken from the patient. If it is taken only from the front part of the nose, then it's not as representative as a test that is being taken like quite in a representative way from the back of the nasal cavity. And at the same time, it can be taken, but still you have a negative result when in fact the patient is positive, and you see the CT results and they are quite positive. See, it can happen, and that's why when we have been working on the position statement, we have been stating that it's possible there is a risk of false negative results, and such risk is there. So it should be regarded very well, and personal protective equipment should be used all the time. Jonathan, your mic is not on.
Oh yeah, there we are. Yeah, just a separate point. Is anyone doing antibody testing on patients? Because we've got antibody testing now for clinicians, and I'm just wondering if that's going to change things in the future as well, and whether we're going to be doing antibody testing on our patients.
Yes, we are doing IgG after 20 days of the first contact in PCR positive and in PCR negative that belong to the same family or to the same group. We are doing that now.
Are you using it as a screening tool before bringing patients into hospital for surgery?
No. I am in a clinic, and we are doing in blood with Abbott and with Epistop also. Because in Mexico, we do need to have some regulations. I would like to have this from Euroimmun, because I think this is a very good test, but we don't have still that in Mexico.
Yeah, there's two main tests on the market. There's the Abbott test and the Roche test. And the Roche test has 100% sensitivity, so the Roche test is the best test.
Well, we have
a lot of people, including us, we're using the Abbott test as well.
We have two protocols in Mexico in the main research areas in molecular biology and genetics, and they are developing some of the IgG and IgM in order to have a rapid test. But I'm still talking to them to see the specificity and of course the confiability.
I think that will really change things, because if we can use that as a screening tool, and if we know patients have had COVID, that may increase our sort of confidence if we can be sure the test is accurate.
Yeah, that's right.
We are not using still the antibody testing for our patients. It is available for in certain places, but we are not using it yet for our patients. No.
I guess it's mainly due to the fact that there are so few cases of COVID positive in our community, so that you wouldn't find many positive antibody cases, so it's not worthwhile in our clinical work yet.
Yeah.
I hope, Timo, when we meet again, we will all be in that category.
Yes.
I'm not sure if I hope for that. Maybe.
I hope we will all have this disease over.
Yeah. What I think is that all this year we have to protect, as we said in our statement, we have to be completely protect. And also, I protect to the patients. I mean, I tell them how to be at home and things like that, because many persons, they do have a lot of confidence at home, and we are still in lockdown, and our cases are still very high, not like Brazilian or the States, but we are having a 128 million population in Mexico. We have a low incidence, but we do have now 100,000 cases in the whole country. So, and because we are very close, like in Mexico City, we have this kind of concern because of the spread, but we shall see.
Wonderful. I'm thankful to all of you. Thanks for the attendance. And as usual, this is going to continue. We will have the next update coming probably in 1 month or 1.5 months of the position statement, and also after some nice editing of the video recorded, we will be having it on our YouTube channels so it can be available. And I'm very thankful to all of you. Hopefully, when we get the position statement published in the journal, we will also have it distributed to you as well. Thankful for the panels. Thanks for for our colleagues, for the co-authors, for the attendees, and looking forward to see you all again, safe and healthy.
Thank you, Ahmed.
Thank
Thanks.
you.
Thanks.
Thank you. Bye-bye. It was very nice to meet you.
Thank you. Thank you.
Bye, Christina.
See you soon.
Thank you. Bye.
Bye.